Thank you for inviting me. I'm going to talk on the Abortion Act and, if you like, the inner legal workings of the Abortion Act and how things have not been working according to the law. I need to start by showing you a couple of video clips from the Daily Telegraph undercover operation, which was done in late 2011 and was reported in the paper in February 2012. And I will show, they're only about 2 minutes each. So we'll start with the, I think it's the Manchester recording. Okay, I don't think the sound's coming through, so I'm going to move on and explain to you what these are all about if you're not familiar. But basically the Telegraph sent an undercover report to 9 abortion providers in late 2011. And in Manchester, Birmingham and London, they recorded conversations to do with sex selection, where gynecologists were presented with a scenario of a woman wanting to have an abortion for reasons of unwanted gender. And really the gist of the conversations was, yes, we can sort this out for you, we don't ask questions. We will, in the case of the Birmingham doctor, they actually decided to say that it was not, it was for the fact that the woman was too young. In the Manchester case, the lady said, I don't ask questions. And so in all of those cases, abortions were facilitated, and eventually the cases were made public and reported to the GMC. Following that, the then Director of Public Prosecutions was presented with the cases, and after some consideration, Keir Starmer wrote to the Attorney General. And I'm going to show you an extract from his letter in a moment to explain why and how things are actually working. In 2014, the Care Quality Commission, in its investigation of abortion centres, identified 67 doctors who had pre-signed abortion forms. And in one case, an abortion facility had been using forms that had been left there by a doctor who had worked there 4 years previously. And in June this year, the Department of Health confirmed that a huge number of abortion notification forms, HSA4, were being returned because the information was incomplete or incorrect. So here's the start of the Director of Public Prosecution's letter in October 2013 to the Attorney General. And I'd like to draw your attention to the really the middle paragraph and the lower part of it. He says that the discretion afforded to doctors under the current law in assessing risk is wide, and there is no generally accepted approach among the medical profession. In the first paragraph, he also says that the reason that he is not prosecuting, well, he had 2 reasons for not prosecuting. The first reason was that he didn't think that a court would accept that these were clearly unequivocally sex-selection abortions. But secondly, he didn't think that there was a case to present to a court that an inadequate assessment had been done. His reasons are given in the middle paragraph in the bottom sentence, which says, on the face of it, the HSA1 form seems to allow doctors to make a decision on abortion without even seeing the patient. So I'd like you to bear that in mind as we have a look at the form to see exactly what is required. So here's the first part of the what's called the HSA form. This is the abortion notification form, and it says, I, Dr. A, of whatever address, have or have not seen and examined the pregnant woman, and I, Dr. B, have or have not seen and examined the pregnant woman. And at the bottom it says, we hereby certify that the woman in question qualifies for an abortion under a certain ground, and it's invariably ground C, which is given as the reason for the abortion. Now, what I'd like to explain is that this has to be a conversation between two doctors, because you cannot authorise an abortion without the two doctors having some sort of conversation with each other, because if it says we certify, it implies that there has been some sort of exchange of information between the doctors. So it's not enough to say that one doctor in isolation makes the decision and the other doctor in isolation. They have to jointly make some sort of risk assessment that is discussed between the two of them. So when the Attorney General says, the Director of Public Prosecution says in his letter to the Attorney General that on the face of it the Abortion Act allows the doctors to sign these forms without seeing the patient, this is not true, because even though it gives each one of them the possibility of not seeing the patient jointly, at least one must have seen the patient. His other assertion that there is no kind of regular standard for consultations in medicine is equally untrue. I don't know how many people are aware of this, but now in medicine there is a foundation program of 2 years, at the end of which this is called Foundation Year 1 and 2, and at the end of that time the doctors go on to a specialist training program. But at the end of Foundation Year 1 and 2, the doctors are invited to apply for specialist training programs. In the GP training program that I'm involved with, you cannot get onto the program unless you have attained a sufficiently adequate standard of consultation skills, which are a core part of the foundation year curriculum. Here's a snapshot of this. Is a summary of the GP specialist training curriculum, which has 26 domains, the bulk of which is the sort of clinical domains. That's things like pediatrics, cardiology, etc. But notice that domain number 2 in the green box on the right-hand side is about consultation. And the GP consultation is at the core of the start of their curriculum. To give you an idea how extensive this is, the section in the training manual for GPs on consultation skills runs to 20 pages. And that's just a few of the references that are given to back up their their program. In other words, a lot of thought and work and real research has gone into what makes an effective consultation. So it is simply not true to say that there is no standard nationally for consulting. Furthermore, in the foundation year program, all the Royal Colleges, what's called the Academy of Royal Colleges, are signed up to these standards. And so even if in the specialist training program, even though a GP may be going into general practice as a speciality, when they're in their hospital posts, they're still being assessed by hospital doctors to the same standard. In 2008, the GMC published its guidelines to doctors about effective communication. This is to do with consent and how patients are prepared for procedures, or how information is transferred during the consultation. And here's some of the advice that the GMC itself gives to doctors in making sure that patients have adequate information. So it says 5A, the doctor and patient make an assessment of the patient's condition, taking into account the patient's history, views, experience and knowledge. And for a relationship between doctor and patient to be effective, it should be a partnership based on openness, trust and good communication. And at the bottom of the slide, this is also taken from the same document, risks can vary, but serious adverse outcomes should be communicated. Not just serious outcomes, but common and minor side effects should be communicated to patients. In other words, according to the GMC, an effective consultation, which involves the kind of explanation of risk to the patient, cannot be adequately done unless there is a full assessment of that risk and communication and explanation of risk to the patient. I'll just let you read some of this, because this is the GMC's own advice to doctors. So if you hold that in mind, you can see how out of line with GMC guidance some of these consultations have been, where abortion is effectively rubber stamped and allowed with virtually no real risk assessment done. The Royal College of Obstetricians and Gynecologists published their latest guidelines to their own members in 2011. And the RCOG is absolutely clear that effective information collection and explanation must be done. So it says all women attending an abortion service will require a discussion to determine their understanding of its implication as part of the process of gaining consent. In 2013, last year, at the end of the year, the Chief Medical Officer wrote to all doctors in the country and said that the expectation is that both doctors will have taken positive steps to obtain information. So we now have a situation where the GMC, the Department of Health, the Chief Medical Officer, and the Academy of Royal Colleges are all unequivocally clear that in order to comply with the law regarding consent to treatment, doctors who are dealing with women requesting abortion must do a thorough assessment of their situation and give the woman in question a thorough analysis of possible risks to her health as a result of going through with an abortion, and have a discussion about alternatives. The Department of Health was actually the latest organisation to provide guidance on this. So in May this year, they came up with this statement that was again widely circulated. So, for example, in paragraph 12, women must be given impartial, accurate and evidence-based information delivered neutrally. So the Department of Health themselves are quite clear that evidence-based information should be given to any woman requesting advice. This is just a diagram that shows that evidence-based medicine is the sort of centre of the patient's knowledge of their own condition, the doctor's expertise, and the external evidence that's brought to bear. And no discussion is complete without a kind of triangulation of all those three things. I want to move on to the abortion notification, because this has also been a subject of controversy with doctors pre-signing abortion forms and what information is actually gathered by the Office of National Statistics from abortion providers. This is a sample form. And I don't know if you can see this very easily, but right at the top, it's got patient's details, patient's reference, hospital clinic number or NHS number, and if not available, their name. Now, there's an obvious anomaly here, because in 2008, the NHS published a document saying that every procedure, every drug that's ever prescribed, every minor sort of activity that's done within the NHS should be recorded with the patient's NHS number, if you like, tagged onto the prescription or the record of the procedure. The reason for this is for monitoring purposes, and so this was actually implemented throughout the whole of the NHS. But it seems that there's only one area that has so far been out of step with this, and that's abortion notification, because the form still gives the certifying doctor the, if you like, the option of not recording the NHS number. And to summarise their advice, they basically want the information to be recorded because it can be it can facilitate audit, and it can basically make it much easier for commissioning organisations to kind of monitor, if you like, the flow of healthcare and how many people are getting how many operations, etc. Without that information, it's very difficult to keep track. And the other reason, of course, is that the long-term research cannot properly be done. And there is some research that only can be done through what's called record linkage. For example, in California, David Reardon's group were able to look at health records from patients who'd been treated under the state of California's own, if you like, their kind of state health scheme, and they linked the health records of these patients with outcomes. And this is women on low incomes who qualified for the state scheme, who had either had a baby born or undergone an abortion, and these were psychiatric admissions in the subsequent 4 years. Now, they did control the study for income and a few other parameters, but they were not able to control for marriage, which was a slight sort of problem with the study. But nevertheless, there is a clear, if you like, protective effect on that aspect of mental health, which lasted throughout the 4 years of the study. That research can only be done by, through large numbers and through adequate record linkage. We can't do such research in England because we haven't got a Department of Health that's forceful enough to insist that proper collection of NHS numbers is linked to the patient's record. In Finland, they did something similar. The Finnish abortion registry was established in 1983, So it's been going for a long time. The Danish abortion registry was established in 1973. So these countries have been doing research for decades, and we still can't do that kind of work in England. So, for example, Gisler and his group looked at suicide in Finland in a BMJ paper that was published some time ago, and they found that the risk of suicide was significantly increased after abortion and significantly decreased after childbirth. And the same group also looked at maternal deaths through accidents, suicide and homicide for several years after abortion. Again, the same pattern of increased risk was noted. So, in summary, the situation is that in order to provide a proper assessment of risk, there is a standard, a minimum standard of consultation, that is now recognised by the Academy of Royal Colleges, which doesn't seem to have been properly recognised by the former Director of Public Prosecutions. I don't think from his letter there is a clear understanding that that there is a kind of robust national standard, and the law is being broken systematically, not only in the at the start of the if you like, the abortion consultation process, but in the recording of information. And there is no requirement for the NHS number to be attached to the abortion record, which is a unique situation in all the NHS. So this is where we're at, and I think I'm going to stop there and we'll take questions. Thank you very much.